Greetings. I'm Dr. Samiksha Khanuja, Associate Professor Himsar, and we are here with the second module of the patient of obstructive lung disease and its therapy. So in this module, we'll be basically talking about the intensive therapy for an obstructive lung disease patient and the intraoperative managements for these patients. So what are the indications for ICU admission in COPD patients? Of course, we know severe dyspnea that responds inadequately to the initial emergency therapy, any kind of changes in the mental status, say lethargy, confusion, coma, persistent or worsening of hypoxia, where the PaO2 has fallen to less than 40 mm of Hg, and or severe worsening acidosis, where pH is less than 7.25, despite supplemental oxygen and the non-invasive ventilation which the patient was on. When there is an obvious need for invasive mechanical ventilation, and of course when the patient is going towards the hemodynamic instability, when there is an obvious need for vasopressors. So how do we do the initial assessment of this patient? When we talk about the spirometry, if you do the lung functions, the FEV1 is less than 1 liters or less than 40% of the predicted. When peak expiratory flow rate is less than 100 liters per minute, it is suggestive of an acute exacerbation in the patient. Very important. Peak expiratory flow rate less than 100 liters per minute. If you talk about the ABG, if you've done an ABG in this kind of patient who's presenting with an exacerbation, most probably you'll find a PaO2 of less than 60 mm of Hg, with or without a saturation of less than 90%, with or without partial pressure carbon dioxide of more than 50 mm of Hg. This all will together indicate a respiratory failure. If you come and do the chest X-ray and ECG, they will of course aid in the diagnosis of right ventricular hypertrophy. You might have some arrhythmias. You might come across and see some ischemic episodes. So how do we begin therapy in such patients? Of course, the first is your short-acting beta-2 agonists. We have salbutamol in 100 to 200 microgram, terbutaline 400 to 500 mcg, phenoterol. If there is no response to these beta-2 agonists, we add an anticholinergic, say for example ipratropium bromide 20 to 40 mcg or oxytropium bromide 100 mcg. So we can all in all use a combination of beta-2 agonists and anticholinergics. Then we've got, along with them, we've got methylxanthins, where we can use either oral or IV aminophylline. Now theophylline, because it has got a very narrow therapeutic range, it has to be tried with a very close monitoring of serum levels. Glucocorticoids. We've got inhaled, we've got systemic. In systemic, normally we use prednisolone 40 mg orally. Inhaled, we've got beclomethasone 50 to 400 mcg or budesonide 100 to 200 mcg. Of course, antibiotics based on a proper culture sensitivity, they have to be administered. Adequate hydration of the patient is very, very important. Controlled oxygen therapy. Now, controlled oxygen therapy is indicated in patients with hypoxia with an aim of improving the oxygen saturation to over 90%. That is, we have to take the PaO2 to more than 60 mm of Hg. We can either use nasal prongs at 0.5 to 2 liters per minute. We can use a Venturi mask at 24 to 28%. Now we have to minimize the excessive oxygen administration. This is very important. Why? Because this excessive oxygen administration can worsen the hypercapnia. How? By abolishing the hypoxic drive, which is very important in the patients with COPD. Next we have is the aerosol therapy. Aerosol therapy, which is indicated for increasing hypercapnia and acidosis. A non-invasive positive pressure ventilation by means of a mask is a very preferred method for this aerosol therapy. If you're using a nebulizer, the airflow in the nebulizer should be 6 liters per minute or even higher to achieve an aerosol. Now, non-invasive ventilation. Non-invasive ventilation, when used in the exacerbation of COPD, improves acidosis, increases the pH, decreases the need for endotracheal intubation, reduces the PaCO2, respiratory rate, severity of breathlessness, so overall the length of hospital stay and mortality. So what are the common indications for the use of NIV in these patients? First, moderate to severe dyspnea with the use of accessory muscles of respiration and paradoxical abdominal breathing or retraction of intercostal spaces. Moderate to severe acidosis with pH of less than 7.35 with or without hypercapnia, that is PaCO2 of more than 45 mm of Hg. Now, we have some conditions which are an absolute contraindication to NIV. One, respiratory arrest, cardiovascular instability like hypertension, arrhythmias, MI, changes in the mental status of the patient, uncooperative patient, patient at a very high risk of aspiration, viscous or copious secretions, any recent facial or gastroesophageal surgery or craniofacial trauma, fixed nasopharyngeal abnormalities, burns, extreme obesity. So these are the conditions where we need to rethink our use of NIV. The modes that we can use in NIV are, we initiate with usually CPAP, which is a continuous positive airway pressure at 3 to 5 centimeters of water, so that the patient is able to sustain a eucapnic ventilation, that is the amount of ventilation needed to bring the PaCO2 to normal. Now the CPAP, it may be given via a nasal mask, a face mask at 2 liters per minute. Now if in spite of this, the condition of the patient deteriorates, then we have to make a decision to assist these patients in ventilation even more. So we can have a next mode, which is the BiPAP, which is bi-level positive airway pressure, which may be initiated with the nasal mask in spontaneous mode with IPAP and EPAP levels titrated to 15.5 with oxygen at say 2 liters per minute. Now, if this patient, despite this, is worsening, then the patient is now in the need of invasive ventilation, and we go ahead with intubating the patient with an appropriate endotracheal tube and initiate the mechanical ventilation. So the indications for invasive mechanical ventilation are unable to tolerate non-invasive ventilation or the failure of NIV, respiratory or cardiac arrest, respiratory pauses with loss of consciousness or gasping for air. If there is a kind of, say, diminished consciousness, psychomotor agitation, which is getting inadequately controlled by sedation. Massive aspiration has happened, our patient is at the risk of massive aspiration. Persistent inability to remove the respiratory secretions. Heart rate is going towards bradycardia, like say less than 50 per minute with loss of alertness. Severe hemodynamic instability without any response to fluids and vasoactive drugs. Ventricular arrhythmias have started to happen. We are moving towards life-threatening hypoxemia. We don't have to think twice in these kind of patients before putting them on an invasive mechanical ventilation. So, if the patient is on a spontaneously breathing mode, we normally got a pressure support or a pressure control mode, where we are supporting the patient with the pressure to generate a tidal volume of at least say 8 ml per kg. We set the minimal trigger setting, flow or pressure, whatever trigger we wish to keep. The peak flow we are aiming is 80 to 100 liters per minute. We can add PEEP starting with 5 centimeters of water with an increment of 2 centimeters of water. If no improvement is seen as you're assessing clinically or with ABG reports, then we go towards paralyzing the patient. So this is just one example of one mode. Say if you're using a volume controlled mode, this is a ventilator setting which you can start with. If with an FiO2 40%, you are getting a saturation of 90%. Tidal volume, you fixed it with say 6 to 8 ml per kg, respiratory rate 12 to 14 per minute, IE ratio 1:3, and flow rate you've kept at 80 to 100 liters per minute. Just a sample ventilatory setting that you can keep in a patient with COPD. Other than that, of course, it is all varying with patient to patient. Now, how do we wean the COPD patient from mechanical ventilation? Weaning or discontinuation of ventilation can be particularly difficult and even hazardous in COPD patients. So most influential determinant of dependency on mechanical ventilation is the balance between the respiratory load and the ability of the respiratory muscles to cope up with that load. I am repeating myself in this. So The determinant of how dependent the patient has become on mechanical ventilation is what balance is there between the respiratory load and the ability of the respiratory muscles of the patient to cope up with that respiratory load. So we need to have two things. We need to increase the strength of the muscles to cope up with that load, and also we should try to bring that load down if we are aiming to wean the patient. So it can be a very, very prolonged and a challenging process. So best method of weaning is like a pressure support or a TP's trial. It's still a matter of debate. How do you wean a patient? In a COPD patient that has failed extubation, non-invasive ventilation will facilitate weaning, might prevent reintubation, but studies have shown that they do not reduce the mortality. Now, what are the surgery-related predictors of pulmonary risk in the patients of COPD? So even with the patient-related factors taken into account, the anatomical side of the surgery is still the most important predictor of respiratory risk. The risk of pulmonary complications is directly proportional, directly related to the proximity of the incision to the diaphragm. If the surgery is, say, outside the thorax or abdomen, the respiratory complications are relatively rare. A surgery which is longer than 3 hours duration will increase the likelihood of respiratory complications by more than 2 to 6 times. So length of surgery, again, very important. So a use of general as opposed to epidural or spinal anesthesia will again multiply the respiratory risk by 1.2 to 3 times. Your use of short-acting muscle relaxants should be preferred. Complications that can arise in these patients after surgery could be because of inadequate reversal, which can cause hypoventilation and a reduced ability to cough. So the preoperative therapy for COPD. So as a general rule, the preoperative management of patients with COPD is the same as for patients with COPD who are not preparing for surgery. We know that there are 4 treatable complications of COPD that must be actively sought, and therapy should be begun at the time of the initial preoperative assessment. Atelectasis, bronchospasm, respiratory tract infections, and pulmonary edema. I repeat, this is what we are aiming for, to prevent atelectasis, bronchospasm, respiratory tract infections, and pulmonary edema. Atelectasis will impair the local lung lymphocyte and macrophage function and hence predisposing to infections. Pulmonary edema can be very difficult to diagnose by auscultation in the presence of COPD, and it may present with very abnormal radiological distribution. Bronchial hyperreactivity may be a symptom of congestive failure, or it may represent an exacerbation of a reversible airway obstruction. So studies suggest that there is a higher incidence of post-operative respiratory failure in the patients who have received GA. But whether it is because of the complexity of the surgery or the operative site or the selection of the anesthesia is really not known. So all the COPD patients should receive the maximal bronchodilator therapy as guided by their symptoms. Only 20 to 25% of COPD patients respond to corticosteroids. Though a patient who is poorly controlled on a sympathomimetic and an anticholinergic bronchodilator, a trial of corticosteroid is definitely beneficial. So in general, a full preoperative respiratory preparation regimen involves a 5-pronged attack on an airway disease. So what are these 5 elements of the preoperative regimen? 1. Stopping the smoking. 2. Dilating the airways. 3. Loosening and removing the secretions. 4. Taking measures to increase the motivation and education. And 4 is to facilitating the post-operative care. They all are instituted and proceeded in a parallel fashion, okay, not singleton ways. Adjuvant medications are antibiotics if there is a purulent sputum bronchitis, antacids, H blockers, proton pump inhibitors if there is a symptomatic reflux. So this is the preoperative regimen. We stop the smoking, industrial pollutants, etc. Minimal exposure to them, of course. Dilating the airways with beta-2 agonists, ipratropium bromide, say inhaled steroids or cromolyn sodium before the bronchospasm. We try to loosen the secretions with proper airway hydration, very important, with humidifier or nebulizer. Systemic hydration is must. Mucolytics, expectorants. We remove the secretions by coughing, postural drainage, chest physiotherapy, that is percussion and vibration. And post-operative care, psychological preparation, pre-operative pulmonary care training is also included in the post-operative care, like incentive spirometry or secretion removal maneuvers, pre-op exercise, weight loss or gain, whatever is required, and stabilizing the other medical problems. Now, management of anesthesia in COPD patients. The key management principles for anesthesia for patients with reactive airway diseases, as I told you, preoperative optimization of bronchodilation, minimal or no instrumentation of airways. So instrument the airways when necessary only when there is an appropriate depth of anesthesia with a bronchodilating anesthetic. Maintenance of anesthesia with a bronchodilating anesthetic. Appropriate warming and humidification of inspired gases. Now, an endotracheal tube bypasses nearly the entire natural airway humidification system. So, humidification of the inspired gases and the use of low gas flows is needed to keep the airway secretion moist. Regional anesthesia is suitable for operations that do not invade the peritoneum and for surgical procedures which are performed on extremities. Lower intra-abdominal surgery can also be performed using a regional technique. General anesthesia, as we know, is a useful choice for an upper abdominal and intrathoracic surgery. So we start with pre-medication. It must be appreciated that COPD patients can be extremely sensitive to the ventilatory depressant effect of sedative drugs like opioids and benzodiazepines. Elderly patients may be especially susceptible to this depression of ventilation. So the most important aspect for preoperative medication is to avoid any inadvertent withdrawal of these drugs that are taken for concurrent medical conditions. We ensure that a perioperative program for intensive chest physiotherapy is initiated preoperatively itself. Regional anesthesia via any peripheral nerve block carries a lower risk of pulmonary complication than either spinal or general. Regional anesthesia is a useful choice in a patient with COPD only if large doses of sedatives or anxiolytics will not be needed. So often a small dose of benzodiazepine like midazolam in increments of say 1 or 2 mg IV, they can be administered cautiously without producing any undesirable degrees of ventilatory depression. Now, regional anesthetic techniques which produce sensory anesthesia above T6 are usually not recommended because such high blocks they can impair the ventilatory functions requiring active exhalation such as expiratory reserve volume, peak expiratory flow and maximal minute ventilation. So it can be even more detrimental. Clinically, this is manifested as cough which is inadequate to clear the airway secretions. So we have to be very careful about a high spinal. So the advantages of regional anesthesia are very obvious, like it's avoiding the airway manipulation which might cause bronchospasm. It's reducing the requirement of sedatives, opioids with ventilator depressant effects. Of course, they are an excellent analgesia. The increase in FRC, normalization of FRC and closing capacity ratio. Preservation of phrenic nerve activity. Now, inhibition of phrenic nerve function via spinal reflex arches appear to be responsible for the diaphragmatic muscle dysfunction seen after the upper abdominal and thoracic surgery. So this activity is preserved when we are using a regional anesthesia. Of course, reduced incidence of DVT, reduced post-operative pulmonary complications, avoiding positive pressure ventilation, very advantageous in patients who might have bullae. When combined with general anesthesia, there is a significant reduction in post-operative intubation time. That is, early extubation is allowed and the requirement for mechanical ventilation after major abdominal surgery is reduced. In general anesthesia, when we talk about the specific anesthetic agents, volatile anesthetics, they cannot stunt the airway reflexes, but they are rapidly eliminated through lungs. So the residual ventilatory depression during early post-operative period is thereby minimized by the use of volatile anesthetics. They produce bronchodilation, they allow delivery of a high FiO2 without lightening the plane of anesthesia. Reasonable degree of cardiovascular stability is maintained by up to 1 Mach. Inhibition of HPV is more or less comparable to IV anesthetics if you are using them in one lung ventilation. Nitrous oxide. Now it has got a potential for passage into the pulmonary bullae, so that might lead to the enlargement or even rupture of the bullae, resulting in the development of tension pneumothorax. Now, another potential feature of nitrous oxide is the limitation on the inspired oxygen concentration that it imposes. So nitrous oxide oxygen mixtures are more prone to cause atelectasis in poorly ventilated lung regions than oxygen by itself. Opioids, they can be associated with a prolonged ventilated depression. Now, duration of ventilated depression produced by the drugs such as thiopental and midazolam can be prolonged in patients with COPD as compared to normal individuals. They diminish the amount of volatile anesthetics to achieve the surgical level of anesthesia, no significant adverse hemodynamic effects. The short-acting opioids, they might be used for smooth transition from surgery to post-operative period, and they permit optimal oxygenation during lung ventilation. Ketamine, it has good advantage as it has got a sympathomimetic property, inhibition of the reuptake of noradrenaline at sympathetic nerve endings. This may contribute to the reduction and inhibition of vagal reflex pathways at high doses. Advantage of reducing bronchospasm in asthmatic patients, no significant effect on hypoxic pulmonary vasoconstriction. HPV, anesthesiologists must be very aware of the possibility of dynamic hyperinflation. Now, inhalational agents, the effect on pulmonary physiology. We know that all the volatile anesthetics, they are potent bronchodilators and they preferentially dilate the distal airways. They increase the baseline pulmonary dynamic compliance, they attenuate the increase in pulmonary airway resistance due to chemical or mechanical stimuli, they decrease the rate of mucus clearance by impairing the ciliary activity, they cause progressive and reversible reduction in pulmonary surfactant. They can cause a biphasic contraction relaxation response in pulmonary vascular smooth muscles. The net effect on pulmonary vascular resistance is relatively small. They've got a relatively modest inhibitory effect on HPV, shunting and oxygenation. They reduce the tidal volume, minute ventilation. They can cause tachypnea in a dose-related fashion. So all the volatile agents, they depress the ventilatory response to hypercarbia and hypoxia by altering the central and the peripheral chemoreceptor function in a dose-dependent manner. Now, choice of NDMR, the non-depolarizing muscle relaxant. We know that atracurim and mevacurim, they cause histamine release and they are better avoided. Though clinically it's not very significant as the effect is of very short duration. Vecuronium cisatracurim do not cause histamine release and they may be satisfactorily used. Older times we used to have D-tubocurarine that caused more histamine release, precipitating bronchospasm in sensitive individuals. Now, analgesia, moderate dose of opioids can of course be used, keeping in mind the respiratory depression. Fentanyl and sufentanil are the potent analgesics with short-lasting effects. Combined epidural analgesia and GA will allow low dose of opioids to be used. In intra-op ventilation, the desired levels of PaO2 and PaCO2 should be maintained. The ideal ventilatory setting should include a slow inspiratory rate to allow the distribution of gas and sufficient time for expiration so that the air trapping does not happen. Optimal tidal volume should be provided and we should try and avoid PEEP. Humidification and warming of inspired gas is very much needed and it's very beneficial. Reversal agents, although cholinesterase inhibitors by increasing the amount of acetylcholine can cause bronchoconstriction, but we normally offset this effect by adding anticholinergics to them. Extubation need to be performed during deeper planes, under deep planes, when anesthesia is still sufficient to suppress the hyperreactive airways. So if this is contraindicated, we cannot, suppose the patient has had a difficult intubation where we cannot perform intubation in the deeper plane, we need to administer, say, IV lignocaine before proceeding with awake extubation. Continuous infusion of lignocaine 1 to 3 mg per kg per hour can also be used in these patients. So, the primary methods to avoid the hemodynamic instability in these patients are ventilatory management through proper pre-oxygenation prior to induction, use of small tidal volumes, slow respiratory rate, and long expiratory times. Tolerance of hypercapnia until the patient recovers from the vasodepressant effects of induction drugs. Also very important for these patients, large bore IV access, vasopressors and inotropes immediately available, IV preloading of colloids or crystalloids. Colloids is a questionable thing these days. Now, lung bullers. Many patients who've got moderate or severe COPD, they develop cystic air spaces in the lungs parenchyma, which are called the bullae. They will often be asymptomatic unless they occupy more than 50% of the hemithorax, when the patient will present with findings of restrictive respiratory disease in addition to the obstructive disease. So previously it was thought that these bullae, they represented the positive pressure areas within the lung which compress the surrounding lung tissue. But now it is very well appreciated that a bulla is actually a localized area of loss of structural support tissue in lung with elastic recoil of surrounding parenchyma. The pressure in a bulla is actually the mean pressure in the surrounding alveoli averaged over a respiratory cycle. So this means that during a normal spontaneous ventilation, the intrabulla pressure is actually slightly negative in comparison to the surrounding parenchyma. However, when we use positive pressure ventilation, this bulla, it will become positive in relation to the adjacent lung tissue. The bulla will expand with the attendant risk of rupture, tension pneumothorax, or bronchopleural fistula. So positive pressure ventilation can be used safely in patients with bulla provided the airway pressures are kept low and there is an adequate expertise and equipment immediately available to insert a chest drain and to obtain the lung isolation if needed. Blood gas analysis in COPD patients. So many COPD patients will have an elevated PaCO2 at rest. Among the moderate and severe COPD patients, it is not possible to predict from their history of physical examinations like which patients are CO2 retainers. Perioperative ABG analysis is required to set the goal for intra and postoperative ventilation. The CO2 retention, it seems to be primarily related to an inability to maintain the increased work of respiration and not due to an alteration in respiratory control mechanisms. The PaCO2 rises in these patients when supplemental oxygen is administered, not due to the decrease in minute ventilation, but because a high FiO2 will cause a relative increase in the alveolar dead space by the redistribution of lung perfusion and also due to the Haldane effect. But still, supplemental oxygen must be administered to these patients postoperatively to prevent hypoxemia. The attendant rise in PaCO2 should be anticipated and monitored. The hypercarbia is usually well tolerated in the absence of any intracranial pathology and if the vasodepressant effect of acidosis can be well managed. Now, in addition to the ABG monitoring, the best monitor for dangerous hypercarbia is the patient's level of consciousness. If the levels are more than 80 to 100 mm of Hg, it begins to have a sedative and an anesthetic effect. Now, if spontaneous breathing is permitted during anesthesia in patients with COPD, it should be appreciated that ventilatory depression produced by volatile anesthetics may be greater in these patients than the normal individuals. Post-operative management. The COPD patients are susceptible to development of acute respiratory failure during the post-operative period. Continued tracheal intubation, mechanical ventilation may be necessary, particularly after an upper abdominal or an intrathoracic surgery. Alternatively, post-operative analgesia with neuraxyl opioids, which permits a pain-free breathing, might permit an earlier tracheal extubation. Prophylaxis against the development of PPC is based on maintaining adequate lung volume, especially FRC, and facilitating an effective cough. Now, identification of FRC as the most important lung volume during the post-operative period provides a specific goal for the therapy. Post-operative neuraxyl anesthesia with opioids will permit early tracheal extubation. The sympathetic blockade, muscle weakness, and loss of proprioception that are produced by local anesthetics are not produced by neuraxial opioids. Therefore, early ambulation is possible with their use. When there is an early ambulation, it will serve to increase the FRC, improve the oxygenation, presumably by improving the ventilation perfusion matching. So, neuraxyl opioids may be especially useful after an intrathoracic and upper abdominal surgery. Breakthrough pain might require treatment with systemic opioids administered by bolus or patient-controlled analgesia. Sedation may accompany the neuraxyl opioid administration, and delayed respiratory depression can be seen, especially when we are using poorly lipid-soluble opioids like morphine. So the patient has to be continuously monitored. The quality of neuraxial analgesia, whether it's epidural or spinal, it may be superior to that provided by the parenteral administration of opioids, but it has not been possible to document that neuraxial analgesia will decrease the incidence of clinically significant postoperative pulmonary complication, or is it superior to parenteral opioids in this regard? So we recommend postoperative neuraxial analgesia in a high-risk thoracic abdominal major vascular surgery. Intermittent or continuous intercostal nerve blocks may be an alternative if neuraxial analgesia is ineffective or difficult technically. Now, very important topic, chest physiotherapy. Actual removal of secretions, it may be accomplished by a combination of postural drainage, coughing, and chest percussion and vibration. Common methods that include tapping with cupped hands and use of electric vibrators for 15 to 20 minutes several times a day. So chest physiotherapy, it moves the peripheral bronchial secretions to more central airways for expectoration by coughing. The effective cough must attain a high enough airflow rate so that it shears the secretions away from the airway wall. In patients with a chronic lung disease, flow rates are low, and shearing of secretions by cough may well be limited to trachea, just the first two airway generations maybe. So with either a chest physiotherapy or cough, it will be much easier to expel the secretions if the airways have already been dilated and the secretions have already been loosened. Now this is chest physiotherapy is relatively contraindicated in patients with lung abscesses, metastasis to ribs, or patients with history of significant hemoptysis or inability to tolerate the postural drainage. Forced expiratory technique is regarded as the more effective technique in removing the secretions than cough. It consists of forced expiration starting from a mid-lung volume to a low lung volume, usually residual volume, followed by a period of relaxation and diaphragmatic breathing. Now, this forceful expiration maneuver will differ from a cough in that it is performed without the closure of glottis and without the accompanying compressive phase that characterizes the cough. Because transpulmonary pressure is less during FET than during a cough, airway compression is less, proximal and distal clearance of bronchial secretion is better than with the conventional cough. So actually FET is now a commonly used alternative to cough during chest physiotherapy. Other lung expansion maneuvers like deep breathing exercises, intensive spirometry, chest physiotherapy, positive pressure breathing techniques are of proven benefit for preventing the PPCs in high-risk patients. They decrease the incidence of atelectasis by increasing the lung volumes. Pre-operative education in lung expansion maneuvers, they decrease the incidence of pulmonary complications to a greater degree than if education begins after the surgery. But there is no evidence that instituting a lung expansion maneuver pre-operatively is of any value. So what is incentive spirometry or sustained maximal inspiration? It is a simple and an inexpensive method that provides objective goals for monitoring the patient's performance. So it's a visual or an audio feedback device that is encouraging slow, deep inspiration. We give a patient a particular inspired volume as a goal to achieve and hold. So this provides sustained lung inflation, which is important for re-expanding the collapsed alveoli. So generally it is performed frequently up to every hour, and its purpose is to treat and prevent atelectasis, especially in post-operative thoracic and abdominal patients. Major disadvantages, we need very good patient cooperation to this. IPPV can decrease the incidence of PPC, but its cost and complexity have resulted in the decline in its use. So this is what we have to do for lung expansion: deep breathing exercises, chest physiotherapy, incentive spirometry, and intermittent positive pressure breathing. Now, what are the PPCs? Post-operative pulmonary complications. Major PPC will be defined as a post-operative pneumonia, respiratory failure, or inability to extubate within 48 hours of surgery, or the need for reintubation after extubation at an end of an anesthetic, either within the operating room, recovery room, or ICU. Minor pulmonary complications include, but are not limited to, atelectasis, bronchospasm, laryngospasm, unanticipated need for supplemental oxygen therapy beyond the initial postoperative period, and PPCs are a significant cause of morbidity and mortality. Postoperative changes include diaphragmatic dysfunction, VQ mismatch, reduction in FRC, which, while measurable, have an unclear relation to morbidity and mortality. The etiology of PPC is very complex and very poorly understood. So these are the patient related factors that can lead to increased PPCs. like age, ASA status, Goldman status, COPD, cigarette use, albumin levels, BUN levels, abnormal chest radiograph. And we've got surgery related factors where you've got the site of surgery, the general anesthesia involved in the surgery, if it's an emergency surgery, if the duration is say more than 3 hours. Many of these factors, they're non-modifiable. So emphasis is basically on the generic risk reduction strategies in postoperative surveillance. So when possible, we need to implement the interventions which are specific to the particular risk factor. Pre and post-operative pulmonary rehabilitation has for sure shown to decrease PPC in a moderate to high risk patients. Lung expansion maneuvers, again very important for reducing the PPCs. Now we know that patients with COPD, they've got a chronically fatigued respiratory muscles. Impaired nutrition, electrolyte endocrine disorders, they all contribute to respiratory muscle weakness, and we need to correct them before surgery. Patients should be examined for any unrecognized cor pulmonale, and if present, they should be treated before the surgery. One modality of potential value in patients is respiratory muscle training. So all the patients that demonstrate increased respiratory muscle strength after muscle training, they are known to have fewer PPCs than the ones who have not had an increase in strength preoperatively. Patients who've got a chronic hypoxemia, they benefit from short-term oxygen administration, which might result in lessening of pulmonary hypertension and reduction in signs and symptoms of heart failure, improvement of mentation. Preoperative finding of hypoxemia should prompt further investigation. Now, even if the hypoxemia is chronic and the patient is not receiving oxygen at home, continuous oxygen administered should be started and elective surgery should be deferred to allow improvement in pulmonary hypertension and heart function. So this is the, in short, the risk reduction strategies in PPC risk that we need to follow preoperatively, postoperatively. These are the risk factors, A, B, C, D. A category, these are the factors. The preoperative strategies are standard practice, and postoperatively we need routine postoperative care. Category B is a little more high risk, where we need to encourage smoking cessation, bronchodilator therapy as needed, and again routine postoperative care. Category C is a furthermore high risk, moderate high risk, where we've got a ASA PS third or fourth, and category D where we've got a ASA status 3 or 4 with severe COPD, room air saturation less than 92, where we might need an ICU bed postoperatively. We need to maintain the scheduled bronchodilator therapy and minimize the postoperative use of narcotics, aggressive multimodal approach for pain management, may have to utilize continuous peripheral nerve blockage. So this is how, what category the patient is in, what is his status, the functional status, his condition of the comorbidities, how our preoperative strategy and the postoperative management differs. We need to know this. So this is the take-home management, take-home message for you all. And thank you so much for your patient listening.